But it's my absolute pleasure to introduce to you Tom Ruffles. Tom's from Brighton and has been doing some great work with Somnath about asthma and about the role of pharmacogenetics in that. Tom.
Good morning. I'd just like to thank Bill for giving us the opportunity to kind of talk about the impact of pharmacogenomics in children's asthma. And just as a brief outline, I appreciate everyone's got we've got a real breadth of professions in the room and breadth of experience, and I was asked to give a real kind of broad overview of really what children's asthma is, because I'm certainly very ignorant of some of the topics that are being discussed later on. We'll have a kind of brief discussion really about the current approach to asthma care in children, and then we'll look specifically at the beta-2 adrenoceptor, the journey so far in terms of pharmacogenomics in that area and where the road ahead may lead. And so kind of briefly, what is asthma? And I've been slightly more bold. So the AV guys were perfect. Were been slightly more bold in terms of including a video from YouTube. And then they warned me there was a possibility that there might be an advert there, so they're going to skip through this bit. But essentially what it will cover, and rather than having to listen to me for 25 minutes, there's a really brief TED talk that gives you a kind of 4-minute summary really of what is children's asthma, which we're hopefully going to be skipping to shortly. Perfect. Thank you.
It starts with a cough or a wheeze. Soon, your chest feels tight. Your breathing speeds up and gets shallower, making you feel short of breath. These are common symptoms of an asthma attack. Around the world, more than 300 million people suffer from asthma, and around 250,000 people die from it each year. But why do people get asthma, and how can this disease be deadly? Asthma affects the respiratory system, particularly the smaller airways, such as the bronchi and bronchioles. These airways have an inner lining called the mucosa that's surrounded by a layer of smooth muscle. In people with asthma, the airways are chronically inflamed, which can make them hyperresponsive to certain triggers. Some of the many asthma triggers include tobacco smoke, pollen, dust, fragrances, exercise, cold weather, stress, and even the common cold. When people with asthma are exposed to these triggers, an asthma attack or exacerbation can occur. But how exactly do such everyday factors lead to an asthma attack? If an asthmatic is exposed to a trigger, the smooth rings of muscle that circle the small airways in their lungs contract and become narrow. Simultaneously, the trigger worsens inflammation, causing the mucosal lining to become more swollen and secrete more mucus. Under normal conditions, the body uses this mucus to trap and clear particles, like pollen or dust. But during an asthma attack, it blocks the narrowed airways, making it even harder to breathe. These effects lead to the symptoms of asthma. Smooth muscle constriction results in the feeling of chest tightness. Excess mucus and increased inflammation can cause coughing, and the wheezing noise? That happens because as the airways constrict, air whistles as it passes through the narrowed space. These symptoms may make a person feel like they're running out of air. Yet counterintuitively, during an asthma attack, the inflammation can make it harder to exhale than inhale. Over time, this leads to an excess of air in the lungs, a phenomenon known as hyperinflation. The trapping of air inside the lungs forces the body to work harder to move air in and out of them. Over time, this can lead to reduced oxygen delivery to the body's organs and tissues. Sometimes, in untreated severe asthma attacks, the body can't keep up, which can lead to death from lack of oxygen. So how do we prevent these uncomfortable and potentially fatal attacks in people who have asthma? One way is to reduce the presence of triggers. Unfortunately, the world is an unpredictable place, and exposure to triggers can't always be controlled. This is where inhalers, the primary treatment for asthma, come in. These medications help asthmatics both control and prevent their asthma symptoms. Inhalers transport medication along the affected airways, using a liquid mist or fine powder to treat the problem at its source. They come in two forms. There are reliever medications, which treat symptoms immediately and contain beta agonists. Beta agonists relax constricted muscles, allowing the airways to widen so more air can travel into and out of the lungs. The other form of inhalers serve as preventive medications, which treat asthma symptoms over the long term and contain corticosteroids. Corticosteroids reduce airway sensitivity and inflammation, so asthma can be kept under control. They're also crucial in preventing long-term damage from chronic inflammation, which can cause scarring of the airways. Inhalers are known to be very effective and have helped many people live better lives. Although we've come a long way in improving how we treat and diagnose asthma, we still don't know its exact causes. We currently believe that a combination of genetic and environmental factors play a role, potentially acting during early childhood. Recent research has even linked poverty to asthma incidence. This may be due to reasons ranging from exposure to additional pollutants and environmental irritants to difficulties in obtaining medical care or treatment. As our understanding of asthma improves, we can continue to find better ways to keep people's airways happy and healthy.
Amazing.
Brain health is wealth. How do we make the brain healthy?
Thank you, guys. I hope that gave you a bit of an overview that was kind of accessible. But why is asthma important? And I think it's the most common long-term condition affecting children and young people. We've got over 1 million children in the UK who are currently receiving asthma treatment. And this graph that you can see on the right makes rather awkward reading for someone who works in respiratory medicine. That's asthma mortality per 100,000 in the age 10 to 14 age group. And the UK has some of the worst childhood mortality rates in Europe. So it's not something that we're doing very well with. Asthma also affects disproportionately our most vulnerable children, and that graph there shows rates of deprivation from some data from Scotland from 2018. And what you see is that you've got a 3-fold greater risk of coming into hospital for your asthma for children that are most deprived compared to those that are the least. And despite all the modern healthcare that we have, over a third of children with asthma suffer from day-to-day poor asthma control. So we're actually not doing brilliantly well with this condition at the moment for something that affects over 1 million people in the UK. So I'll just give you a really brief overview of the current approach to asthma management, and it's a one-size-fits-all guideline approach. Rather unhelpfully, there's 3 different guidelines that cover children's asthma, which make things slightly confusing. They don't always agree. And for people that might have a bit of a background in kind of pediatric healthcare, the table on the right is what you see from the British Thoracic Society guidelines. And as the video is mentioning, that talks about using a reliever medication in the first instance, which is often salbutamol, and then adding in preventer therapy over time, which often starts with inhaled corticosteroids to try and manage things, and then escalating through depending on how the symptom control is. The most common reliever medication is salbutamol, which I imagine many of you will be familiar with. It's a beta-2 receptor agonist. It relaxes the smooth muscle in the airways, but is a short-acting medication. And with that, you need preventer medication. This is just an example of 3 of them that we commonly use. Inhaled steroids that decrease inflammation, leukotriene receptor antagonists such as montelukast that decreases leukotriene-mediated inflammation, that isn't being used quite so much really due to kind of issues with respect to its efficacy, but also some undesirable neuropsychological side effects. And then more commonly now, there's combination inhalers that are being used more and more in children with inhaled steroids plus a long-acting beta-2 agonist, and guidelines are actually advocating that these are used more, which decrease inflammation but also relax smooth muscles and open up the airways. Now, for anyone who's worked in children's healthcare and asthma, you'll know that some asthma medications seem to work really well for some patients, and the next child that you see in clinic, the same combination of medications don't work. And this paper from 2010 from Lynn Tosig's group from the New England Journal shows that really clearly, that for those children on inhaled steroids already with asthma, those with the long-acting beta-2 agonist, something like seretide, do better on the population level, but there's still a proportion of children that actually that leukotriene receptor antagonist is better. And then how do you determine which child should get which medication? And so it's really clear now that with these individual genetic differences may well explain these variation in terms of how children respond to these medications. And this one-size-fits-all guideline approach isn't really working. So I'll just bring it into the kind of the area of research where we're involved, and specifically looking at that beta-2 adrenoceptor story, where that's come from, and potentially where that's going to head into the future. I guess there's two important caveats with that. The pharmacogenetics around children's asthma is incredibly complicated. I'm going to talk to you about one gene. There's clearly going to be hundreds that are going to be involved with the individual responses for children's medications. But this is certainly the gene in the area where there's the most robust data in children, and there's the strongest clinical signal, but also importantly that does not appear to be a signal for this in adults. So this is something that's purely, the data is there for children. And so this is the beta-2 adrenoceptor. It was described in respect to the polymorphisms associated with its effect in asthma in the early 90s by Stephen Leggett's group in Florida. So it's a beta-2 receptor polymorphism at position 16 that makes an allelic substitution from glycine to arginine. And this beta-2 receptor is found predominantly in airway smooth muscle. Some of the early observational studies, so this paper's from 2006 from Somnath's group up in Dundee when he was working there, and looked at over kind of 500 children from Scotland, and found that there's an increased risk of exacerbation that those are homozygous for the AA mutation as opposed to the GG mutation. But particularly in children with the long-acting, using that long-acting beta-2 agonist, that risk increases even further. And that was followed on by a 2013 paper that was published in Clinical Science that shows, specifically looking at those people with the AA polymorphism, the homozygotes, so 62 children already on inhaled steroids, that if they had montelukast instead of that long-acting beta-2 agonist, they had decreased school absences, which was their primary outcome, and improved quality of life. And so the hypothesized mechanism is that you get agonist-induced downregulation with this long-acting beta-2 agonist, you get uncoupling of the beta-2 receptor, and then it impairs the efficacy of this beta-2 agonist that is so kind of fundamental for asthma management. And the real kind of game-changing landmark paper was Steve Turner's meta-analysis that was published in JACI in 2016, on behalf of the Pharmacogenomics in Children's Asthma Consortium. And that took kind of data from 5 different cohorts from all around the world, over 4,200 children. And that showed a real clear link that for each copy of that A genotype that you had, there was a 52% increased risk of exacerbation when you're using that long-acting beta-2 agonist. And this was a real game changer, really, in terms of providing the evidence of this association. Follow-on work from that is the PAC trial that was published in ERJ in 2020. And that took children and randomized them to beta-2 genotype-based prescribing versus standard care in primary care. The scatter plot there is looking at their quality of life outcomes over the 12-month follow-up, and the dotted line is the MCID. And there was a significant improvement in quality of life in those children that had the personalized beta-2 based prescribing opposed to standard care. But whilst it was statistically significant, it was just below the MCID. But for those who are homozygous for the AA polymorphism, it was clearly above the MCID. But importantly, we're starting to build this evidence base for kind of prescribing around this polymorphism, but what the children and what the families think about that. And Dan Hawcutt, who's here in the audience today, will be doing one of the kind of sessions later and relating to pediatrics that I'm really looking forward to publish this paper in 2022 in Archives that's really important. That's exploring children, families, clinicians. What do they feel about this? Do they feel this is necessary? Do they feel this is important? And they do. And they showed really nicely that children and families are happy for their genetic information to be shared and to be used to try and improve their asthma care. And this was really the first work to explore that. So potentially, where does the story go from here? Where are we hoping to take this? And there's a meta-analysis that's due to be published shortly with Ankie Hilse's group from Amsterdam, and I think they were planning to be here, but I can't actually see them in the audience at the moment. Elisa Slob, who's part of her lab, will be the first author on that publication. It's a really nice meta-analysis looking at a group of patients that they had recruited from Holland and Switzerland in the Puffin study, combining that with some of the data from PACT that we've published previously that showed that beta-2 genotype-guided care versus standard care actually decreased asthma exacerbation rates, which is a really kind of powerful outcome for children's asthma, and that's due to be published shortly. And then a kind of follow-on work really looking at what children and families think, and this is the Pristine 2 study that again will be published shortly, and that's looking at implementation of this beta-2 genotype-guided personalised medicine in the clinic setting. Is it feasible? Is it acceptable? And I had another really nice video from one of the teenagers involved in the study who then got really shy a couple of days ago when I told them what we were planning to use it for and declined. So it reduces my stress from having another embedded video that might go wrong. But I think, as you can see from some of those quotes, the families really engaged with it, the children really engaged with it, they found it was incredibly useful, and they couldn't really understand why this isn't being offered to more people. So where are we going next with this? And I guess we've demonstrated that there's a benefit there. We've shown that this is something that clinicians, children, families are really keen for, and we've shown that it's something that can be done feasibly. And so the next step really is to kind of look at the financial side of things, and I guess this is where we're really fortunate, and it shows the real strength of the network here, that off the back of kind of meeting with Bill, they've put us in touch with Catherine Payne and Sean Gavin from Manchester, and they're going to help with that next step, which will be looking at the health economic side of things, and they're due to be undertaking some work in that domain shortly, and we're really grateful for that. And I think that just shows how well the network works, that they were able to link us together for that. And that will be the next step really on that kind of road to implementation. Is this something that's going to be potentially feasible for us to do? So we're really grateful. Thank you. Any questions at all?
Thank you very much, Tom. I mean, the scale of the issue, I mean, the figures that you give, the numbers of children that are affected by asthma and the numbers of children having to go into hospital and missing school, I mean, really such a terrible disease. And the fact that, you know, the outcomes in the UK are really just not where we want them to be is something that we really need to address. And of course, pharmacogenetics isn't the only element of that, but it's something that is an important element, and if we can sort of incrementally do all the things we can to help, that'd be really great. Any questions for Tom? Yeah, Munir, please.
Thanks. That's really interesting, and it's good to see that's coming through, because it's been around a long time since Steve Liggett's time and things like that. So you said it's only relevant for children but not adults. Can you just let us know what the reasons, pathophysiology behind that is?
That's a really good question. In reality, we don't fully know. The thought process is that essentially you're dealing with different conditions. And in children, it's often allergy-driven component. And there's also a thought that in adults, there's greater rigidity in the airways, and there's less kind of flexibility in the airways, and that's the thought as to why it's not seen. The studies are really equivocal. Some have shown a benefit, some haven't. But that's the kind of current thought behind it. But in reality, we're not fully sure, to be honest.
Can I just follow up?
Yeah, of course, Munir.
So how did you, in your trials and the other trials that you've done meta-analysis
think that's a wonderful question. And the reality is, so the PACT study was undertaken in primary care. It was all done remotely. And so adherence is a huge problem in children's asthma. If you're looking at inhalers, you're looking anywhere between kind of 40-50% adherence often in some of the studies that are done. And we weren't able to fully review that. We didn't have a mechanism within that to do that. But that's going to be a huge... There are ways you can do that in terms of looking at prescription rates. There's also electronic monitors that we use in our difficult asthma clinic. And certainly, I think going forward in the future trial designs, that's going to be something we're going to incorporate if you're actually going to get some kind of robust data around that. But yeah, that's one of the huge challenges we have in children's asthma.
Tom, I think chatting with yourself and Somnath, I was interested that you flagged that the allele frequency for this variant differs quite a bit across different populations. Do you mind just mentioning a little bit about that and which groups you think may particularly benefit from this intervention?
Yeah, absolutely. So if you're looking at the Steve Turner's meta-analysis that takes data from kind of 5 different cohorts, and absolutely it seems to be in the ARGE kind of polymorphism that in Caucasian patients in the UK you see in about 1 in 7, about 15% of children, where you get the really clear benefit. If you look at different populations around the world, that's expressed differently. And so it does seem to be something that's more beneficial in the white European Caucasian population. That signal is less clear from data sets in South Africa, in North America, where the populations are more mixed.
And is there a sense that there may be other variants, or that it's just different genes, different mechanisms in those other groups, or is that still a bit unclear?
Oh, absolutely. So there's so much work around this and away from the beta-2 receptor, looking at steroid responsiveness, looking at montelukast, and there's a huge amount around that. And there's been some fantastic publications from the Peak Consortium around this area. And I guess that will be one of the next steps going forward, will be, can you try and incorporate other markers? At the moment, it's the beta-2 kind of that's looking at the strongest clinical signal, but can you incorporate other markers as well and bring that into a more comprehensive package for GPs, for example, to give them a clear, but we're quite a way off that at the moment.
Perfect, thank you. And you very nicely flagged the workshop that'll be coming up in a little bit, which Dan is going to be facilitating, which is focusing on pediatric pharmacogenetics, clearly an area where there needs to be more work. I mean, around pharmacology, you know, lots of the studies aren't done in children for all sorts of reasons. That makes it very challenging. But it's an area that we think there's some unmet need, and so trying to explore that with Dan and colleagues, you're more than welcome, those of you that want to join that group. Okay.